I think it's really important, firstly, because breast cancer is the most common cancer in India today. It makes up 14% of all tumors that we, newly diagnosed tumors that we see. And women that are affected in our country are younger. They're about 20 years younger than the West. So you can imagine a situation where the entire family has to kind of get involved with the costs of care. There's no health insurance in our country, national health insurance. So most of the patients pay out of pocket. And the more elaborate you get with treatments, yielding smaller and smaller benefits in terms of just months of survival benefit or a few months of progression-free survival benefit, may not really translate into a very effective situation, because it can actually drive the families below the poverty line, and that's what's happening. So you need to be careful, and certainly where agents that are available with like a year plus of overall survival benefit, please, I mean, those are things that we should push for. But at the same time, keep in mind that it's just a statistic. All patients don't get cured, or all patients don't derive that survival benefit. So when you're talking to the patients, I think you need to be a little more realistic in our setting. So, I can give you a few examples. Like in the West, when you look at the guidelines, and we very often refer to the European guidelines or the UK guidelines or the NCCN guidelines from the US, and for metastatic breast cancer, they do insist, most institutes, on rebiopsying the tumor. Our question is, why are you wasting money on that if it's in keeping with the clinical context? If it is, then don't biopsy. But if it isn't, and you're suspecting that you get suddenly get a HER2 positivity, which you could target in an otherwise negative patient, by all means. So choose your situations where you would biopsy and not biopsy. If a PET scan is not available or is frightfully expensive at a large distance, you can make do with a CT chest and abdo with bony windows, and that will give you enough information to treat the patient. So you don't need to over-investigate. When you're treating with metastatic tumors or even early breast cancers, you don't need to do molecular profiling. You just need a good ER, PR, and a HER2 to make basically all the clinical decisions that are required. You don't need a fancy NGS testing or a large panel, which seems to have become the fashion these days. So be careful who you pick and choose when you're thinking of BRCA testing. Look at the family history. Don't just test randomly every woman that walks into your clinic. So look at the criteria. Similarly, when you are advising expensive drugs like anti-HER2 agents, make sure your HER2 test is done from a validated lab, because you don't want to be wasting money on a treatment that is not going to be effective. And everybody doesn't require dual anti-HER2. There are so many that can't afford it. Single anti-HER2, trastuzumab with chemo works just as well. So you need to, even though there is a survival advantage, you must remember there is a sequencing of therapy that is going to happen in metastatic patients. So at some point of time, you will get a clinical trial in the time period of the patient. Encourage your patients to go on clinical trials. Treatment is good, it's well monitored, and it's free of cost to those patients. So you have to think of these things. Everybody today who is ER positive is receiving a CDK4/6 inhibitor. A more reasonable option may be just combining fulvestrant with an AI up front. It's giving you 8 months survival advantage at like literally 1/3 the cost. So there are ways of choosing wisely for breast cancer situations. I'd just like to add, for the younger oncologists out there, look at the clinical context in which you're using all these new drugs, because trial requirements are very specific and very stringent, and that may not be the case with the population you're seeing in your clinic. So don't expect a new drug to perform miracles where it's not fitting in that very population that was studied. I think sometimes oncologists have unreal expectations from the treatment, and that brings up the patient's expectation as well. as a result, the patient feels that if I don't spend this money for this treatment, I'm causing grievous harm to my patient. So just be a little wary about the populations you're selecting for newer treatments.